So my topic, not a very nice one, it's a very sad one, but the most important topic nowadays, I think, we've talked about cannabinoids, we've talked about CBT, we've talked about a lot of topics which are now discussed in the palliative world. So passive euthanasia, I have actually been given this topic to look into the current clinical and legal perspectives. So this is my basic slide where I'm going to talk to you about what it is, what are the clinical dilemmas, and what we are facing in the legal field. So before I go through, how many of you are comfortable with talking about death? Can you raise your hands? Okay. And if death is actually being looked into, do you think that the perceptions that you've had through your experiences color the way you actually talk to your patients about death? Yes? Yes, no? So then it becomes very important, because when we talk, are we putting our own perspectives into it when we are putting it across? Or are we actually individualizing the care for every patient and caregiver's perspective? Because the two can be very different. So it can either be where it is very gloomy and, lack of hope and, this is not going okay, this is what you need to do. That actually puts people down. Or you could say a positive side of it, of how the journey that they're making towards the end that they're inevitably going to face, is that something that can be made better? Okay? And that involves a lot of decisions. And since we live in a country where we are multicultural, the societal beliefs and facts, the customs that every religion goes through, North India, South India, were very different. The physician attitude towards death, or the professional attitude towards death, institutional policies, all carry a great impact on how we talk about death, or what we are talking about today, that's passive euthanasia. In the middle of all of these things is something called law. Now, all these days, it was not a part of what we were doing. But in the recent years, they have woken up and they are there with us and trying to make policies. And as clinicians, it then becomes very important for us to understand what those laws are so that we can translate it into clinical work. Otherwise, it's like two different fraternities doing what they want to do and nobody's actually for the benefit of the patient. So we said that we are okay about talking about death and dying. But then how do we break down the barriers? Do you think there are barriers? I think it's pre-lunch, but then, do you think there are barriers? Yes. So do you think we have a great role to play in breaking down those barriers? So let's just see how we are, okay? So let's go back a little bit in time. So this has to be a journey that the societies that are there in India have worked towards what we are talking about today. There are two big ones, the Indian Society of Critical Care Medicine, which started their journey about talking about how patients were dying a very difficult death in ICUs. They were having treatments given which was not benefiting them. They were on ventilators for a long period of times. And that caused a lot of difficulty for patients as well as their caregivers, not only psychologically, physically, financially. Okay, so then came along the Indian Association of Palliative Care around 2014 when they started meeting prior to that and they said, we need to do something about this. Okay, so then they came about with an integrated plan for the dying. And in the years to come, a couple of years around that journey, they came up with an end-of-life care policy in India. They also got out a consensus position statement that talks about what end-of-life care is, when do we start talking about it, what do we talk in end-of-life, what are the things that are required when you're going to make this conversation, and how do you prepare, and what is good death. And all of that actually brought about an awakening to say there is a different way to talk about death. Okay, so as clinicians, we practice these 4 pillars or core principles of ethics. What are they? First one is autonomy. We all like to tell everybody what we like, isn't it? So then the patient would also like to do that, which means we have to give a lot of value and respect, whether it is a Muniyamma from Kanyambadi in Tamil Nadu or it is the CEO of a company. Each one of us have our own wishes, and giving respect for that is important. Beneficence is acting in the best interest of the patient. Non-maleficence is avoiding harm, and justice is equitable care, health care to all who come to us. So we understand now that there is an importance for end-of-life care discussions. We've made our journey. We've said this is a very important part. And ESMO has actually given a level 2A evidence that this is necessary. So how many of you have ever had end-of-life care discussions? Okay, so what happens here? So in end-of-life care discussions, why have they given a level 2A evidence to say that it benefits? Because it decreases their distress. It gives a platform for them to talk about what their challenges are. We are able to guide them, which means unneeded, non-beneficial interventions for artificial life prolonging can be avoided. Before that, they did not have a platform to talk about it. Society said, if you don't put your loved one into ICU, then you're not looking after them. You're thinking money is more important than looking after your loved one. Nobody actually thought through the prism of a patient's view. Okay? So that became very important. But then clinicians do find these conversations difficult. No matter how many times we talk about it, a family will come along and you think, how am I going to talk to them about this? Okay? The reason being, sometimes there's a prognostic uncertainty. Sometimes there is a fear of causing distress. You don't want to upset them. They're already crying. We are already saying, oh my gosh, they look depressed. They need psychological support. And here I'm going to say, I'm sorry, but there's nothing more you can do. Or I'm sorry, but this is not going to be beneficial. And sometimes when we talk about it, we can change a person who's quiet into an angry person. Then how do I deal with that? Collusion, where the patient does not know what's going on. How do I deal with that? And how do I make sense of end of life in that situation? Lack of skill in breaking bad news and medical legal issues. So, the world internationally as well as in India, we've come out of some ways in which the medical fraternity can have an objective way of looking at it, okay? So, these are called prognostic tools. So, it is validated by ESMO. There are a couple more who can actually look into it. So when you're faced with somebody who is declining clinically and you are looking after them, rather than being a subjective thought, make it more objective. It makes it easier to show, easier is not the word, more clarity in actually showing to the family or to the patient, if they are actively involved in these discussions, about the time that they've got. Why do you think it's important? Anybody? Why do you think it's important for a patient to know that they have a certain X amount of time left? Why? Unfinished business, isn't it? There has to be closure for caregivers. You have to have the opportunity to say what you want to say and hear what needs to be said from the patient side. But otherwise, if we don't do it, one of the barriers is this invisible wall that we build. And it's impossible to break. And we think we'll tell them and everything goes wrong. How is that okay? Yes? So unless we are convinced about the timing, it becomes very difficult. So what is the time? What's the right time? So this is the normal trajectory of an illness of a person who is actually not responding to treatment. Okay, we are not talking about survivors. We are not talking about people who have responded to therapy and they're doing great, right? We're talking about somebody who is not doing so great. So what happens? There is a place where they decompensate. Now you have your palliative prognostic index. You know that things are not going okay. So that should ring an alarm bell in your head and say, I have to somehow find a way from this point onward to have a conversation with the family, right? So how do you go about it? How many of you heard of this surprise question? Yeah, it's a wonderful question actually for ourselves. This is not for the patient. All right, please, it's not for the patient, it's for us. When we are actually looking at the patient's trajectory, how they are, the surprise question is, would I be surprised if Mr. X or Mrs. X would be passing away in about 6 months or in a year? Whatever you want to look at. And if the question's answer is, no, I would not be surprised, then we need to wake up. And we need to say, maybe the time has come where I need to start introducing. And none of these conversations are all held in one consultation. You sow a seed, you wait. You sow the second seed, you wait. So unless you start earlier, you are going to land up in a point where their dependency and symptom burden increase, and then the family is so focused on the symptom burden that they're not willing to listen to you about anything else. If you think that the decline and terminal phase is the right time, you have actually missed the boat. Because at this point of time, it's very difficult for family to accept what you're saying, and the time required to have these conversations is too long. So then we are left with the ethical issues we've got, and we've got, are they going to sue me for this? Do I have my institutional support for this? If they come back and tell me this doctor forced me not to put my patient onto the ventilator, do you have the clarity about what you've done? Have you documented? If that understanding is not there, that is when we land up with medical legal issues. Okay? So, the medical fraternity and the legal fraternity decided, let's get together. All right, so what did they do? For the past 24 years, actually, there has been a fight to die with dignity. It's been a long journey. We've not heard about it. There have been many individuals, not oncology, but many individuals who've gone in and they've put in a petition to say, I don't want to be put on a ventilator. I don't want to die in this way. I have a right to say how I want to die. But the Supreme Court of India and different courts squashed it. The reason being, they were citing what is called as Article 21. What does that say? It says, if I have a right to live, I have a right to die. But suicide, murder are also dying ways. Okay, so there was a very, very grey line. And as we've been saying from morning, different shades of grey. And so we really needed to be very careful. So things were moving very slowly for 24 years. And then all of a sudden, in 2005, like I told you, ISCCM started to make a movement. They started to talk about it. They started to talk about it from the medical point of view, not from a patient's point of view. And so they went on a journey. 2011, we owe it all to Aruna Schanberg. There was a lot of talk that happened for the painful life that she had. But from that painful life grew hope for the people in the future. And it was at this point of time that people started talking about what's passive euthanasia, what is withholding care, what is withdrawing care, what is right and what is wrong. And so from 2011 to 2014, then 2017, the Mental Healthcare Act said, I want something like that. Because I am filled with people who are vulnerable and I need to protect the way they die. Okay? So, the common cause judgment in 2018 was the landmark judgment for all of us. They upheld the fact that there was a right to die with dignity. They recognized advanced medical directives. They laid out procedures, but their procedures were gruesome. Their procedures were too difficult to follow in practical manner. For us as clinicians, for the patient's relatives, where all do they run? Who do they ask for? And so it was difficult, but it also paved the way for India in international waters, where we could also hold our head up high and say, we have entered into ethical end-of-life care in India. Nobody can say India is not a good place to die, which they did say in 2015. There was an international consensus that looked upon how the quality of dying was in many countries, and they looked at 80 countries, and we were somewhere in 67th rank. And they said, it is terrible in India. And so the fraternities woke up, and there was a second one in 2021, and it said we had moved up. We were better. And that was because of the hard work of the people who have paved the way for us. So Article 21, what does it say? It is a right to life, and it includes meaning that I have a freedom from suffering, freedom from prolonged, undignified suffering. And that is what passive euthanasia is about. It's not about killing somebody. So let's just go through very quickly what these definitions are. Okay, what do I mean by withholding life-sustaining treatment? Are you all with me? Yes. So withholding means I am not going to initiate something. Or maybe I'm in 4 liters of oxygen, but I decide I'm not going to go up to 10 liters of oxygen. Okay? So it's either I'm not going to start something or I'm not going to escalate what is going on. That is called withholding of life-sustaining treatment. What is withdrawal of life-sustaining treatment? Withdrawal means something is going on. And I am saying, I don't want this to go on. So whatever is happening, I am going to withdraw it. So that is in the end, whatever happens, I am not causing death. Death would have happened anyway. All right, so that's very clear that we need to have in our mind. So, withdrawal and withholding life support or medical treatment in a person who has a terminal illness, where cure from the issue is not definitely going to happen, and where death will happen naturally, is what is called as passive euthanasia. So what is the purpose of passive euthanasia? The purpose is to allow and protect an individual's right to die with dignity, to prevent prolonged futile suffering for patients who have irreversible conditions. Of course, we are talking cancer here, but there are multiple other facets that are there to palliative care where they have chronic illnesses. And that is something we are talking about. So the key principle, like I told you, clinical ethics, what were they? Autonomy, beneficence, non-maleficence, and justice. So passive euthanasia is the principle of balancing autonomy with non-maleficence. I will not harm my patient. Okay? Everybody clear on that? Yes? Okay. So then we come to the fact that understanding death would happen not because we withdrew or withheld treatment, but it would have happened naturally anyway. And we are giving them the right to do that. Active euthanasia, on the other hand, is not that. Active euthanasia is Amelia Sahana Michael is going to take an injection which is lethal. I am going to go to a person who is having a life-limiting illness, and I'm going to give this medicine that will end the patient's life. Whether the patient asked for it or not, it is illegal in India. Everybody clear on that? Okay. So, I know this is a very busy slide. I think they're going to give you the slide so you can look at it. But this is where the difficulties came, if I may. So, when a person has an advanced medical directive, okay, what happens? The patient goes into an ICU or they go into a situation where they say, no, I don't want to go ahead with this. But no single doctor, even if you're the admitting physicians, can take a call on this. It has to be a team that does it, okay? So what 2018 judgment said, that they wanted actually the jurisdictional judicial magistrate first class to come and to look at all of this. You imagine, is that practical? It's not practical. Okay, then what happened? It was not the doctor who had to inform the family. It was the magistrate who has to inform the family. Okay, it's like me saying, I'm going to go and fight a case in court. I have no clue what I'm going to do. Yes, but they had to do it. Then they had to hand over a copy to any of these official places, and they then have to nominate a person who could then be an authority to hold this AMD for the individual. Nobody had been nominated so far. Then they had to, the authenticity of this advance directive, they had to go through an extensive process. They had to talk to the relatives before it got finalized. So if we go down this road, there were multiple factors that was not possible for us to practically concern this. And in the end, if we have to actually look at this, the people who were on the board, there had to be 3 members, and together they should have had 20 years of expert practice. Not possible. So then a writ petition was given, and therefore a writ petition was actually submitted to tell the Supreme Court, please listen to us. As doctors, it is impossible for us to do all these things that you're asking us. You are helping us, but we are unable to do it. So they listened to us. And in 2023, there was a judgment that was then released of accepting advanced medical directive, of putting into place and getting things done in a simpler manner. But they then had the job of laying down the law that clearly distinguished between allowing a natural death and causing death. All right? So it's their job to lay down the law, and it's our job to understand it and talk to the relatives in the right way. So what is a living will? A living will is also called an advance directive. I can do it, you can do it. Today you can do it. Okay, it basically says that when the time comes when Amelia Michael can no longer speak for herself, either because natural causes or a calamity, she has made an advanced medical directive where it tells the treating physician or the hospital and the family, I want this done, I don't want this done. and it has to be upheld. All right. So in the advance directive, what did they change? What did the Supreme Court of India change? The first thing is they said it is not only about being terminally ill. You should not be of sound mind, meaning I should have lack of decision-making capacity. If I fulfill that criteria, then the treating team can then decide whether life-sustaining treatment is vital or not. Is it benefiting or not benefiting? If they decided it is not benefiting, then the hospital should have already got a primary medical board. The time for them or the expert advice given, they needed only people who had less than 5 years experience. And there is a rule set out for who all can be on that board. Once the primary board actually gave the clearance, the treating doctor then gives the information to the family, which is much better. And they had to talk about the pros and cons, and by not giving life-sustaining treatment, what would happen. And when the family consented to that, or the patient consented to that, then a secondary medical board was informed. And the judicial system set out a time frame this time to make sure things happen properly. It had to happen within 2 days. No pulling feet, no dragging feet. All right. The secondary medical board would then have to say if they agreed with the primary medical board. Everybody with me so far? And from the time of secondary medical board to actually carrying out the order, it's only 48 hours. So effectively, by the time you decide to conducting actually the withdrawal or withholding, you had only 4 days, which in 2018 was not there. Of course, if the secondary medical board says you cannot do it, I can put in a petition to the High Court to have a talk about it. Okay, so they've made that provision as well. Now, Karnataka did a fantastic thing. Now, Karnataka publicly accepted legally that they will accept the right to die with dignity. And that is a fantastic thing because any of us living in Karnataka can get this done and we can get it notarized. And it has to be legally looked into by the hospital. So that's what the legal system did. So as clinicians, what should we do? Do you think this is an easy journey? It's a very difficult journey, isn't it? So the most important thing that we would like as a palliative fraternity to talk to all the juniors or the colleagues that are here, please look after yourselves. These are very difficult conversations. They do affect us. And if we are going through similar situations, it makes it very difficult to actually be very, logistical and involved in such discussions. So be taught, understand the psychology, like Dr. Michelle was saying. Understand who's sitting in front of you. Understand who you are. Reflect on a conversation. After having a difficult conversation, if you need time, don't go into your next consultation. Take a few minutes. And if you have somebody to talk to in that period of time, do that. Because otherwise, if you ignore yourself, the more and more kind of these conversations you have, they are going to take an effect on you. And that is where they say palliative physicians have the highest burnout. Okay? So to prevent that would be really good. Okay? To understand, respect, and be concerned. We do have challenges, bureaucratic, lack of awareness, ethical, healthcare inequality, fear of persecution. These are ongoing, but we will work on it. And so take-home points is communication is important at the right time. Understand when to do it. Have a balance with your ethical values, prognostic tools, and the legal protocols. Have a clear understanding of what passive euthanasia is because relatives will ask you questions and you cannot be confused in front of them. Primary and secondary board in your institution, work with the administration to get one done because it is the legal need right now. And an interdisciplinary team, psychologist, very, very important. Okay, and self-care is an absolute must. So thank you. I hope it's been clear.
Thank you so much, Amelia.